a conference called Shots for Tots, and it's basically a conference to talk about the latest information on immunizations and to encourage providers to go out there and immunize children and adults.
We have no financial incentives or relationships with any of the manufacturers, commercial partners, products, or suppliers of commercial services. Dr. Rebecca Gee, she currently serves as the Secretary of the Louisiana Department of Health, having most recently served as the Medicaid Medical Director for Louisiana and as an Associate Professor of Health Policy and Management and Obstetrics and Gynecology at LSU. Dr. Gee completed a Robert Wood Johnson Clinical Scholars Program at the University of Pennsylvania and there received a Master's of Science in Health Policy Research. She studied history and obtained an MPH at Columbia University in Health Policy and Management. She also obtained her medical degree at Cornell and trained in obstetrics and gynecology at Harvard, at the Brigham and Women's and Massachusetts General Hospitals. Dr. Gee has served at both state and national leadership roles in public health policy. She has advised the public health departments of several states, including Louisiana, Pennsylvania, Ohio, and Massachusetts. She has served as chair or co-chair of several national committees on maternity, quality, and prematurity reduction for the Centers for Medicare and Medicaid Services, the Maternal and Child Health Bureau, the American College of Obstetrics and Gynecologists. Dr. Gee is the health policy resident expert for the journal Obstetrics and Gynecology and serves on the editorial board. Dr. Gee is on the Institute of Medicine's Board of Health Care Services and is the inaugural recipient of a 2-year Gantt Fellowship at the IOM. She has won several awards locally and nationally and is clinically active in caring for patients in LSU. And with all of that, she still has time to come and talk to us today. So I present to you Dr. Gee.
Thanks, Dr. Johnson. I had the pleasure of seeing Dr. Johnson at Opelousas General. We got to do an event a couple weeks ago to celebrate the impact of Medicaid expansion in her area. And congratulations, Dr. Johnson, for your award, and to Krista O'Neill, and to so many of you. It really makes me happy. I see a sea of women in here. I see a few men. Raise your hand if you're a man. How many? What? Okay, all right. Well, thank you for being here. But you know, why are women, I was thinking about that, why are we more involved in vaccines for kids? I think, the one thing Dr. Johnson didn't mention, and I think probably I'm an obstetrician, but probably my primary qualification for being here is I'm the mother of 5 children. I have twins who are 4, a 10-year-old, and twins who are 13. So we have had a lot of vaccinations, and I personally, with that many children, know how hard it is when you're a busy working parent to get your kids immunized. And, one of the really, really important, every public health area has challenges, but vaccines have had a lot of challenges because there have been a lot of misinformation, right? There's been a lot of information. There have been certain trends like autism in the nation, and people link to vaccines without really good data linking them. And so we've had things like the measles outbreaks happen because parents have made choices not to immunize. But of all of the public health interventions, in fact, of the year 2000, there was a list of what are the top 10 things that have really saved the most lives in the 20th century. And of course, vaccines tops that list. There's no single intervention that has been more life-saving other than antibiotics, than the invention of vaccines. So vaccines have the enormous potential to prevent disease and disability. And of course, as an obstetrician, I'm biased, but I think the most important members of our society for the future overall are women of reproductive age and our little vulnerable children. And so it's so important to make sure that we get women vaccinated and vaccinate their children and make sure that we do very well on that. So one of the things that we do in Louisiana very, very well is that we have great parties and we have great festivals, and we know how to do that. We're the best in the nation, and we have the best food, but we do the worst on health. I'm wearing this red symbol. What's that for? Does anyone know? HIV, actually. Today's World HIV Day. And I was just speaking to, there was a group from the White House and the Surgeon General's here in New Orleans today. In fact, I'm going to leave a little earlier than the program because he's here, and we found out last minute he was coming. But he's here to talk about AIDS. So in New Orleans, for example, we're number 3 highest city in the nation. New cases of HIV. Louisiana is 2nd highest in the nation, so not doing very well. You look at obesity and heart disease. You look at prematurity, we have a long way to go. And I'll talk about coverage, which I think is an important piece of why we're not doing well. But we've done really well on vaccines. We meet or exceed the national average on vaccines. And why is that? Well, many of you, and how many of you have been here since '92 when you started? Any hands? How many? Yay. So this is a long effort. So in 1992, my understanding is there was a measles outbreak in Louisiana, and folks got together and said, this is not right. We've got to do something about this. Let's organize, create the Shots for Tots coalition, and let's create a data source, the LINKS program, so we can figure out who's gotten them and what their vaccine lot was in case we have a problem with that. And let's figure out how we do pay for performance around vaccines so providers have an incentive to do it and they know what their rates are, and you've made a difference. So vaccines are an area where, as Secretary of Health, frankly, I should be more worried about it, but if I look at my top 20 things of what are the worst things we're doing, vaccines are not on it. You have succeeded. So let's just take a second and applaud ourselves for the success we've had. So infectious diseases, and when we talk about vaccines, we're talking about preventing the spread of infectious diseases. Infectious diseases are the low-hanging fruit in healthcare. Frankly, it's tough to be thin. If it was easy to be thin, we'd all be thin. It's tough to, you can't control if you get cancer, right? You can't control if you have a family history of heart disease. But you can control the spread of infectious disease. You can wash your hands, and as you know, with 5 kids, I've got a petri dish in my house, so I can't always control it, but you try it. You wash your hands, you do things. But vaccines are the most important. Vaccines are the thing that is the best guaranteed way to not spread infectious disease. And so we are able to make, because there is an intervention and it's easy to do, it's a one-time intervention, we're able to, for many vaccines it's a one-time intervention, like the flu vaccine every year, we're able to prevent the spread of infectious disease. And that is something that we can do in Louisiana. And even though we've been very successful, and your efforts have really resulted in very good rates, we're at 73% of our kids before 35 months have been vaccinated, and that's very good. You want to be at 90%, so we're not all the way there. You want to be at 90, but that's not bad. That's a big amount of progress that we've made in Louisiana, so I want to commend you for that and just stress how important it is and how children, of course, are the most vulnerable. One of the things that I fought for, previous to this role, I was the Medicaid medical director for the state of Louisiana, and I don't know if Kelly wanted to recognize Kelly Finwell, who's on my staff, and she knows, having been on my staff for a while, that one of the things that made me the maddest when I was in that job is we did not pay for pertussis vaccine for pregnant women. And it was only going to cost us something like $400,000 for the entire state to immunize, and it would have saved, we thought, about 12 to 14 babies from dying. And I could not get the former administration to approve it. And it just killed me. Because you think about, we spend money on so many other things, but to me, that is fundamental. A vaccine is fundamental, and preventing babies from dying is the most important thing that we can do. And so one of the first things I did when getting into this job was say, we're going to change that. We're covering it, by goodness. So anyway, but those are the kinds of things that are stupid policy decisions, not to cover vaccines and not to make sure we have comprehensive coverage for things that we can prevent, and spending way too much money on the long-term problems, the end of life, the cancers that could have been prevented, but now someone's really sick and getting that tertiary care. So in this country, we have a long way to go in thinking about how we prevent disease and save money by making people healthier. And of course, vaccines are the front lines of that effort. And I commend you for your focus and for paying attention over the next couple of days to this issue. So I wanted to talk a little bit about Medicaid expansion, because I do feel, and of course in Louisiana, as you know, due to the efforts of my predecessors and people like Ruth Kennedy, who's been the Medicaid director and formerly in eligibility, we have done a great job at getting kids in Louisiana covered. But we have done a horrible job at having adults covered. So between 1 in 3 and 1 in 4 working adults in Louisiana prior to July had no form of coverage other than an emergency room or potentially out-of-pocket FQHC, but not a comprehensive way of coverage. It was called patches of care. You know, you might get a little care here, you might get a little care there. And I'm still practicing in gynecology, and I would see it all the time. In New Orleans, as you know, this is a community of musicians, artists, hotel workers, the people that, I don't know if they probably don't have an open bar here because we can't afford it in public health, but if they did, the people that would be giving you drinks at your bar, at your conference, all those people typically make too little money to afford. Either their employer doesn't provide insurance for them, or they can't afford the Obamacare insurance, and so they go uncovered. And what happens is they put off, and particularly women, you know this, we typically prioritize our family and our parents and others before ourselves. So time after time in my own clinic, I would see musicians or women. In fact, I saw one a few weeks ago who finally got covered, but here she came in and she had probably what is a grade 3 metastatic breast cancer that she waited to get treated because she felt the lump and thought, oh, well, it kind of maybe got smaller last month, let me wait. She finally got insurance, came in, and we biopsied it, and there it was. It was probably, she hasn't had her lymph nodes biopsied yet, but it's a very a severe tumor, so it's likely that it's metastatic, but that shouldn't happen in a country that's the wealthiest country on this earth. My view is we've got to cover. We can have conversations, and I'm involved in one now that I think is very important at the national level, which is our drug costs too high, right? Should companies be able to, if there's no competition, no transparency, and you can price it whatever you want, but the public has to pay for it anyway, that's a wrong system, and that's what we have in drugs. So we have certain parts of healthcare that are way out of control on costs. We're spending money on things that don't work, things like back surgery, you know, a couple weeks after people get pain, you know, doing things that are not driven by data or guidelines. But the basics, coverage for primary care, coverage for vaccines, we have done a very bad job in this country making sure that everyone got the fundamentals. And what has that resulted in? Well, it's resulted in one of the most expensive healthcare, the most expensive actually, healthcare system on this planet. And for that spend, and I look at value as what's value? It's you get value when you get a lot for your money. Well, we're not getting a lot for our money, so we have a poor value system because people are still, if you look at the US versus Germany versus Sweden and versus, frankly, some of the developing countries, we don't do as well in some areas. So a long way to go, but coverage is important. Just having access to basic primary care, very important. So I'm proud to say that as of today, because of Governor Edwards' decision to expand Medicaid, we have over 351,000 people in this state who have coverage. Those are people that prior to Medicaid expansion, and I think more importantly, and I'm an obstetrician, so in my view, the most pressing problem was this: we only covered women when they were pregnant, right? But 3 weeks or 6 weeks later, they would get kicked off their insurance. And so but we expect them to come back pregnant the next time healthy? No, doesn't work that way. You have to have coverage in between to treat the conditions that are diagnosed during pregnancy, including making sure that women are up to date on their vaccines, up to date on their general care. And so we've had coverage. Most of the people we've covered are women. A little bit over 60% are women. And most of them are young. So we're talking about women of reproductive age who are the majority of the people, of the group of people who are in our coverage, and they're women who are going to have the children who need the vaccines. And so what's important about that, too, is that when women are in a general source of care, and you all know this because you're in the trenches, right? How many of you are providers or, you know, interacting with families, giving immunizations? Okay, so you know that if people are involved in a regular source of care, they're much more likely to know what the guidelines are and be comfortable and have a place to bring their children. If women don't have a regular source of care, it's a lot harder to teach them and coach them as to how they can get their kids vaccinated. So having these women is very important. But one big criticism that you'll hear on the opposite side of expansion of Medicaid is, well, you'll give them a card, but who the heck cares, right? Because no one will see them. We pay too little rates for Medicaid, so no one's going to see them anyway, so who cares if you expand Medicaid? Well, I have data to say that that's not true. So we've given 351,000 people coverage, but since July, we've had almost 30,000 people go to a primary care visit in the state of Louisiana. 30,000 people, not just made an appointment, went to the doctor. We've had over 3,500 women, and my mom died of breast cancer, so this is the one that I really care about. They got mammograms. Okay, they would not have gotten a mammogram likely if not for expansion. We've had over 36 women diagnosed with breast cancer because of Medicaid expansion who would not have otherwise had that opportunity. Those are 36 women who can be mommies to their kids a lot longer than if we had waited too long and they didn't have a mammogram. We've had over 2,000 people get colonoscopies, and of those, over 700 have found precancerous polyps. That's 700 people just since July who would have had colon cancer that would have been a hell of a lot more expensive to treat if we'd waited, that we picked up through a colonoscopy. And on and on. We've had over 1,500 people diagnosed with hypertension. Hypertension, of all the chronic diseases, is the one that leads to death and disability, heart disease, stroke, but these things are preventable, and diabetes. And what happens if you don't diagnose diabetes? Well, you get loss of limb, loss of sight, loss of touch, loss of quality of life that's tremendous, and we can treat diabetes. So these are all things that are happening and are happening as a result of expansion. And I just want to, this is an interesting time. We do not know what will happen nationally, but the folks who are in leadership positions now have said they will repeal Obamacare. What that would mean for our state would be a $4 billion, 4B, not M, $4 billion hole of money we would lose in $500 million state general fund. And those monies don't only go to Medicaid, but Medicaid, because we're a poor state and we get enhanced federal match, we actually help support roads, prisons, higher education, all of those things. So if you cut Medicaid expansion, all of those things will suffer. So my hope is that it's a lot easier to say you'll repeal it than to take coverage away from 20 million Americans, 350,000 alone in our state. So I'm looking forward to what I hope is a more constructive conversation than just a repeal, and think about replacing, because there are major problems. The Obamacare exchanges are a major problem, right? The costs are going up, insurers are getting out of that market. Blue Cross in our state is fixing to leave this year if this doesn't get fixed. The exchanges have to be fixed, but the Medicaid expansion has been a great success, and our costs in Medicaid have stayed at or below national inflation. So you have as a total incremental cost of services. So it's a conversation we need to have. But in Louisiana, we have had a great success with coverage and access that I hope we can maintain, because I do think there are a lot of challenges to improving health. Of course, our behaviors are the most challenging. And in a state like Louisiana, where the food is as good as it is, probably diet is our biggest challenge because we're the most obese state in the nation. That's hard to do. It's hard to stop smoking. It's hard to do all the right things. But coverage is important because that way at least you can get diagnosed and you can prevent death and disability before it happens, and help keep families strong, help make sure that women of reproductive age are immunized and healthy going into pregnancy, which is really important because it's healthy women make healthy children. So I am excited. I hope that you all figure out how to get us to 90%. I just saw, excuse my cough, Frank Welch walk in. He's been phenomenal. He works for us. Stacy has worked with us. For many years, 2 decades, so we've had a number of really, Henry, we've had a number of really, really great advocates who work both in and out of the public sector for vaccines and for public health in this state, and we have an A team, just a tremendous team. So I look forward to you all helping us continue to succeed on vaccines and make sure that we stay right on target with where we need to be. And please let me know if there's anything that the health department is not doing, and we'll change it.
Dr. Wharton currently serves as the acting director for the National Center for Immunization and Respiratory Diseases. She received her medical degree from Harvard Medical School and master's in public health from Johns Hopkins School of Hygiene and Public Health. She completed her internship and residency in internal medicine at the University of Michigan Medical Center in Ann Arbor, Michigan, and her infectious disease fellowship at the Duke University Medical Center in Durham, North Carolina. Dr. Wharton joined CDC as an Epidemic Intelligence Service Officer in 1986 and was assigned to the Tennessee Department of Health and Environment in Nashville, Tennessee in 1989. She began work as a medical epidemiologist in CDC's Epidemiology Program Office. She joined CDC Immunization Program in 1992 and since that time has held a variety of positions of increasing responsibility. In 2006, she became Deputy Director of the National Center for Immunization and Respiratory Diseases. She has worked extensively on issues related to vaccine policy, vaccine safety, science, and public health response. Dr. Wharton has authored or co-authored more than 80 scientific journal articles, book chapters, and CDC publications. Prior to Dr. Wharton coming up, I just need to state our disclosures for the conference.
I am delighted to be here in New Orleans and getting to attend your annual conference. This is one of my favorite places in the world, and so I was glad to have a chance to come back. What I'm going to be talking about in my first presentation is HPV vaccination and making the case for why we have to do better and how I think we can do that. It's important to engage the entire practice, not just the healthcare provider, in committing to improve HPV vaccine coverage. I certainly hear stories as I talk to pediatricians in particular that when they started working on it, they realized that not everybody on their staff really understood the rationale for HPV vaccination. There might be people who had heard something or had a concern or for some other reason who just weren't supportive of HPV vaccination. And everybody in the office needs to know this is their responsibility to help make this thing happen, that it's important, that it's going to save lives. And there was a study done in Southern California Kaiser where they interviewed clinics that were doing better with HPV vaccination and clinics that were doing worse, and really did identify that having a culture in the clinic that supported HPV vaccination was helpful. And so things that were reported to them were things like a local culture that supports series completion, teamwork among clinicians, promoting series completion as the provider's role, and giving vaccines is just standard. That's just what we do. So all of those things were identified. Interestingly, the bar on the right is that they make the return appointment for subsequent doses. There's that again. And I know that some appointment systems don't necessarily allow you to make a return visit at 6 months of age or 6 months after the first dose, but it would be really good if it did, because then you wouldn't have that disconnect between what the parents expect and what the clinic actually does. Which brings us to implementing system strategies to improve HPV vaccine coverage. So what do I mean by system strategies? Well, this is what I mean. Standing orders for HPV vaccination beginning at age 11 to 12. So you don't have to wait until the provider signs something to give the vaccine. Conducting reminder recall beginning at 11 to 12 years of age. Let families know that, that HPV vaccine is recommended. This is, wait a minute, we'll get to that in a minute. Assessing HPV vaccine coverage at every visit and prompting clinical staff to give HPV vaccine at that visit. Scheduling the return visit for the next dose before the patient leaves the office. There's that scheduling thing again. And then, of course, documenting delivery of immunizations in the child's medical record and the state's immunization information system. This is another study from Southern California Kaiser where they evaluated the effectiveness of a letter in the mail on series completion for girls and young women who had started the series but not completed it. And I think they sent a couple of letters at 3-month intervals. And the letters went to the parents for kids under 18, and it went to the young woman herself for those over 18. And letters to parents actually got kids in to get subsequent doses. Interestingly, letters to young women did not get them in. And having 3 children in that age group, I could completely see that. My children don't read their mail. But anyway, that's another reason to not wait until they're 18 and older. So I said all that stuff. Well, does this really work? Yes, it does. And there's a paper that was just published in Pediatrics in October that shows that if you actually do these things together, that you can achieve high immunization coverage. In Denver, Colorado, there's a health system that's mostly federally qualified health centers. Large health system serves a large population of mostly disadvantaged people in the Denver area. And they decided they were going to get their kids vaccinated with HPV vaccine. And so these are the interventions that they made. They actually have an electronic health record system that is comprehensive and that is also linked to the state registry, but for their kids, they pretty much deliver the services within their system. So they used their immunization registry function to record vaccine history and recommend needed vaccines at every visit. The medical assistants were trained and did check the vaccine registry for recommended vaccines at every visit. They had standing orders for routine immunizations. They give the vaccines as early in the visit as possible. So if the parent doesn't have questions, the kids get the vaccines before the provider even comes into the room. Their providers have been trained to talk about the vaccines as a standard bundle of vaccines that are recommended together. They provide provider-level feedback on adolescent vaccine coverage rates, the way I showed you that clinic in Texas does. And they also have some school-based clinics, which they use to deliver some immunizations. And with those tactics, this is what they were able to do. This is their coverage for Tdap at the top, meningococcal conjugate vaccine, HPV vaccine, 1 dose for girls, which is the line that starts in 2006 and goes up pretty rapidly, and 1 dose of HPV vaccine for boys, which is the line that starts in 2009. If you put in place all the systems interventions that are recommended, you can get high coverage, at least with 1 dose, which is what this slide illustrates. Now, they didn't do quite as well with 3 doses as they did for 1 dose, but they were still well above the national average. So this actually can be done. This is not a incredibly well-resourced clinical setting. This was a network of federally qualified health centers that had the same kind of staff turnover and IT challenges and everything that everybody does. Now, for the most part, their kids were vaccines for children eligible, so in terms of reimbursement, maybe they had fewer issues than some providers might in private practice. But this can be done, and I think this recently published paper really makes that case. So for those of us who aren't in clinical practice, what can the rest of us do? Well, there's a lot that community and state level organizations can do. And in fact, by having this conversation here at this meeting, both this presentation and some others that are going to be given at the conference, some of the exhibitors who are here, American Cancer Society is here exhibiting, we can all work together to commit to implementing effective strategies. Immunization programs can do AFICs focused on adolescent immunization. Provider organizations like the state AAP chapter and the Family Physicians chapter can help their members develop the motivation and skills to make an effective recommendation for HPV vaccination. And I know the state AAP chapter has been very active here. Cancer programs can help motivate immunization providers to prevent cancers caused by HPV in their patients. You know, there are still pediatricians who just sort of think it's not that bad, or it's not that big of a deal, or it's not their patients, and it is that bad, and it is their patients. And the people who work in cancer are good messengers for that. Healthcare payers can use HPV vaccine coverage as a quality measure. There is a HEDIS measure now that includes HPV vaccination in both boys and girls, along with other adolescent vaccines, that will be updated now that the schedule's changed, but the 2017 HEDIS is actually based on 2016 data, and the 3-dose and the schedule change didn't just happen, so that should be fine. So there's time to get that measure changed. And all organizations that work to increase public awareness and support for HPV vaccination as cancer prevention, as well as promoting and implementing system strategies to improve HPV vaccine coverage. This one is important. And you know, the thing that I keep thinking is, in 10 or 20 years, there are going to be young people who have cancer because their doctor didn't give them HPV vaccine, their parents didn't ask for it or said no, and those are cancers, some of which are going to be fatal, that could have been prevented if we had just given the recommended vaccines. This is now the standard of care, and anybody who's not doing it is actually not practicing standard of care medicine. We have an opportunity to prevent cancer in our young people. You know, some people are too old to have had an opportunity to be vaccinated. But we've had this vaccine for 10 years, and now any cervical cancer in a woman under 36 years of age, or, you know, high-grade cervical lesions, is at least theoretically could have been prevented with vaccination. We have to do better on this, and I think everybody in this room can be part of the solution to help protect our young people, your young people in the state of Louisiana, from cancers that are now preventable. Thank you.
Dr. Marshall received his undergraduate degree from the University of Pennsylvania and his medical degree from Vanderbilt University. After completing a pediatric residency in Vanderbilt, he entered a fellowship in infectious diseases at the Children's Hospital of Philadelphia, CHOP. He then joined the Department of Pediatrics at the University of Louisville School of Medicine, where he's now Professor of Pediatrics, Chief of the Division of Pediatric Infectious Diseases, and Director of the Pediatric Clinical Trials Unit. He also serves as an attending physician at Corsair Children's Hospital. Dr. Marshall has won numerous awards and recognition as a clinician, educator, and administrator. He is a member of the Society for Pediatric Research and the Pediatric Infectious Diseases Society, and has served in several national leadership positions. He has authored over 150 papers and is best known for his work in vaccine development, advocacy, and education. He is also the author of the Vaccine Handbook, a practical guide for clinicians, the Purple Book, now in its 5th edition. And if you guys look in your bags, you have a Purple Book. How awesome is that? I present to you Dr. Gary Marshall.
It's great to be back here. I've spoken at this conference before, and I was chatting with one of the folks outside. I'm trying to remember when I was here, and it must have been 5 or 6 or 7 years ago. There was a woman named Gina that was in charge of things, and I think she's passed on. But anyway, thank you for having me again. So we've got about an hour to have sort of a more or less didactic interchange about vaccine hesitancy. And then we have about 45 minutes to do something a little bit more dynamic and a little bit more interactive, where we can take some of sort of the theoretical underpinnings of understanding vaccine hesitancy and try to translate that into words and action. And I mean in the exam room with the hesitant family. So before we go too much further, I do need to let you know that I do have potential conflicts of interest. I work very closely with all of the vaccine manufacturers, both as a consultant and also as a principal investigator. So these are the official objectives of the first part of the program, and that is to try to develop an understanding of why people are so prone to accept anecdotal experiences as indicating causal relationships. The question I want to leave you with, and then we're going to have a discussion about all of this and how to translate it into real life, is how can we maintain high coverage rates in the face of this pervasive vaccine hesitancy? Well, as an educator of medical students and residents, I would like to argue that the pendulum has swung way too far to the left in terms of medical education. Who knows who this is? Marcus Welby. You're showing your age. My students and residents have no idea who that is. How about this guy? He's not a doctor. He's a singer. That's Pete Seeger. So Pete Seeger, in my mind, is sort of the epitome of the kumbaya approach to life. Sit in a circle, hold hands, and let's relate to each other. Marcus Welby, on the other hand, is the epitome of the authoritarian, paternalistic family practitioner. Mom, listen to me. I know what's best for your child. So where are we? Kumbaya or Marcus Welby? And I'm going to argue that we're way too kumbaya. We teach our medical students that their families are their, clients or something, and that we partner with them in the care of their children. Well, guess what? My doctors didn't partner with my parents. They just told them what was right, and they went on and did it. And so I'm wondering if maybe we need to swing a little bit more over to Marcus Welby and be a little bit more authoritarian in that way. So our real job is to convert the anecdotal thinking that I've illustrated into scientific thinking, to convert that heuristic rule of thumb thinking into deductive reasoning, to move folk numeracy into statistical numeracy, where somebody stops and says, wait a minute, the vaccine didn't cause the pregnancy loss, that just happens, 16,000 out of 10 million times. We want to go from patternicity, seeing patterns where they don't exist, to hypothesis testing. So what that would mean is making 100 pieces of toast from the same toaster and now looking at how many of them show the image and how many don't, right? That's hypothesis testing. We need to change the perception of risk into a risk-benefit analysis, and then to change the tragedy of the commons to the common good. So the tragedy of the commons is a term that was in a very famous paper in 1968. It was referring to the environmental crisis. And basically what it refers to is, if you have a grazing commons and you have surrounding herdsmen who have herds of cattle, it's within each herdsman's rational self-interest to allow his cattle to graze in the commons, because his cattle will feed and they'll grow. But if every herdsman acts in his own interest, the consequences for everyone will be predictable. The commons will collapse and all the herds will collapse. So I like to make this analogy in that we have to get back to a little bit of the way it was in the greatest generation, which is we're all going to take on a little bit of risk, even if it's the risk of a sore arm or a fever, in order for there to be a common good. And then I'm just going to leave you with this quote from Neil deGrasse Tyson, who's kind of taken Carl Sagan's place as the popular cosmologist and physicist. he says the good thing about science is that it's true whether or not you believe it, right? So we've got to get back to science and away from belief. And so that's all I have for a formal presentation. And I'm going to ask Carmen and maybe another helper person on this side to take the microphone. And I'd like to run through some scenarios, and these are things that you live through every day in your practice. And I want all of us to hear from you what you do about this, how you handle it. And I'm going to introduce this workshop by a few slides that just kind of demonstrate some strategies, right? So how do we practicalize all this? How do we operationalize it? One piece of advice is to begin the discussion early. One of the good things about Tdap in pregnancy and IIV is that we get to talk about vaccines with women who are pregnant and who are going to have a baby soon. So we can emphasize the importance of vaccination. How many of you are involved in prenatal meetings, like pregnant women who are coming in to talk about the vaccine or the care of their babies, right? Just a few. How do you do those, Carmen? How do you schedule those like evenings or weekends, or how do you do that?
Well, generally, if we have someone who's searching for a pediatrician, they can schedule a prenatal visit where those moms come in and we discuss their beliefs, whether they're going to breastfeed, whether they're going to immunize, and try to address those questions at that time. See if we make a good fit. If not, then we can, refer to place.
So, I mean, that's kind of a prophylactic strategy where, listen, I'm just going to head this off before the baby's even here, right? Because you need to know, Mom, that this is our stand on this. Sorry? Somebody say something? Okay, there's a mic here if you want. Hep B in the nursery, another opportunity to talk about vaccines. And this whole idea is to normalize vaccinations. That is to make vaccines the norm, not the exception. Have a plan. So outline the scheduled vaccines for each visit. So Mom, when you come in at 4 months, this is what we're going to do. With 6 months, make sure you give the vis. Explain the importance of each vaccine, screen for contraindications. You know all of this. Anticipate the common side effects. So you don't want it to be a surprise that there's going to be a fever. So, yeah, Mom, there might be a fever, but here's how to handle that. Take a strong position, okay? This is the so-called presumptive approach as opposed to the participatory approach. So the presumptive approach is, I got good news for you today, Mom. I'm going to prevent your daughter from getting cancer, meningitis, and whooping cough. Do you have any questions? As opposed to, what do you want to do about shots today, Mom? Or, I got good news for you. I'm going to prevent your daughter from having meningitis, terrible disease, and I'm going to prevent her from having whooping cough, which has had a little resurgence lately. Oh, by the way, there's also this HPV vaccine, so if you want that, you can get that too. Do you see the difference? That's the participatory, and it's not a strong approach. So be persistent. Mom hesitates? Listen, I'm leveling with you. These shots are really important. Hesitation again? My kids got these shots. In fact, I can tell you, my daughter, when she was a freshman in college, maybe, the HPV vaccine was just licensed. She came home for Thanksgiving, and I said, honey, while you're home, you're going to get started on the HPV shots. And she said, no, I'm not. And I said, well, yes, you are. She said, no, I'm not. I'm not going to be in one of your little experiments. You want to use a team approach. It's got to start in the waiting room. So you have a Vaccines Are Us sign in the waiting room, and then the receptionist has a Vaccines Are Us. Hey, good news you're here today. We're going to get those shots in. The person the MA who brings you back and weighs you, and she's talking about the vaccines, and then you're there to answer any questions. We need to be consistent within a clinic, within a practice. You can't have some providers who are lenient and some who are strict and some who have one belief, some have another. It's not going to work. Everyone has to be on the same page. And the visits have to be organized effectively, right? So, preparatory phone call, then a screening questionnaire, then the brochures and take home and try to minimize the amount of time you've got to fight the battle in the exam room. You don't have the time to do it. How many patients do you have a practice, or how many patients you see a day? 30 or 40 patients a day. What if half of them are there for well child and half of them want to have an hour-long discussion about the vaccines? I already pulled out my hair. Actually, that happened when my daughter turned 12. You need to also layer the information appropriately. The way you approach one mom is going to be different than another mom. So think about this. How would you approach Sheldon, and how would you approach Penny? You're going to use a different argument for each of them, right? Because they're different people. How many don't know what I'm talking about? Sarcasm, no. You want to emphasize disease risks, not the vaccine prevention. In other words, and this was a study that looked at what if we try to correct the parents' beliefs about autism and vaccines, or just don't do anything beyond the standard, or what if we emphasize not the autism vaccines don't cause autism, but we emphasize how terrible measles is, and now we know in this country 1 in 1,700 kids who gets measles might get SSPE and die from it. That was just presented a little while ago. So you want to emphasize the disease risk. And when I say normalize vaccination, let me tell you about a study that was done in a hotel just like this. You know those things that say, we want you to help keep the earth, whatever. And we want you to reuse your towels, right? So that saves energy and all this other stuff. Well, a lot of people do it and a lot of people don't do it. So they did a study where they randomized rooms to have a little tag that said, help us respect nature and do that, or join your fellow guests and reuse your towels. And which do you think, randomly, which do you think the rooms reuse their towels? It was the ones that said, join the rest of us. So people want to feel like they're part of a group, and they want to join the others, and that's what normalizing immunizations mean. You've heard about motivational interviewing. There are all these different, it's another one we need to take. Who is that? Okay. Get the name out of the thing. Motivational interviewing is sort of a technique for bringing people around to realizing something on their own. And there's all these different methods, AAA, ask, case. Honestly, I don't know how much any of these really work. I think you'd get just as much bang for the buck if you just took the approach that Marcus Welby would take. So here's something from one of William Carlos Williams' poems. It says, it is difficult to get the news from poems, yet men die miserably every day for lack of what is found there. I think another way to say this is communicating with patients is not about using or not using a particular phrase or style of conversation. It's about finding a way to connect with another person in the midst of this frightening universal business of living and dying. So let's try to connect with families. So you're in the exam room, and I want somebody to give us an idea of how you would handle this. And mom says, thank you, but I know why you want my kids vaccinated. And I know why the companies, I know why Sanofi and GSK, I know why they want these kids vaccinated, because they make money when these vaccines are used. And that's why I don't want to participate. How would you deal with that? What would you tell mom about that? Somebody, the mics are here, just raise your hand, take the mic, and tell me. You can't tell me you've never heard this complaint. what would you say to that family? Got one over there. And then we're just going to give the mic to people.
Well, I'm really silly. I'll tell them I'm not giving your kids vaccinations to make money. I'm giving them vaccinations so they don't make my kids sick. So that's how I counter that, and then give them the VISs and go over the shots.
Well, I know you're telling me that, but first of all, I know also that there's no polio anywhere in the Western Hemisphere, so you can't tell me that giving that polio vaccine to my kid is going to prevent your kid from getting polio, because it won't. There is no polio. So the only thing that's happening here is I'm paying for this, and Sanofi is making the money.
It costs me, man. It costs me money to give you vaccines. So
Oh, come on. Okay. I'm sorry, but where do you live?
I believe it's Louisiana.
I don't know any Louisiana. I mean, I know, Doc. Come on, I see your car out in the parking lot. And I know you live in this fancy part of Metairie or whatever. That's one of the suburban, anyway. I mean, come on. I mean, I'm a plumber, and we work hard for a living, and you can't tell me you're losing any money here.
Plumbers make more than that.
Yeah, that's true. Any other thoughts about what you would say in this situation? I mean, I think it is true that your practice, if maybe breaks even, giving vaccines, but you certainly don't make a lot of money giving vaccines. But what about the companies?
How can you put money over your child's life?
Okay, so, that's the argument that, it's not, you're getting me wrong here. It's not that I'm not willing as a parent to spend the money. Sure, I mean, I'll spend the money because it's, I could do that, or I could buy him a new pair of shoes or whatever. But it's really more that I really detest the fact that that money is going to these big companies that are making a fortune. So here's something that you might not know. If you added up the entire world market for vaccines in 2014, it's about $1.5 billion. If you added up, no, I'm sorry, this is the market for Pentacell. I think that's what's shown there. Across the whole world, if you compare that to the entire world market for Lipitor, that's $13 billion. So, Mom, if I was a company and I wanted to make money, vaccines would be the last thing I would make. Because I'm going to invest $1 billion in developing this thing. I have no guarantee anyone's going to take it. And I'm not going to make any money. I'm not going to recoup that $1 billion investment. I'd rather make another statin, because you who take Lipitor are going to have to now take my statin every day of your life till you die. And that's how I'm going to make money. So to me, that's a way to counteract that thing that a parent might say. What about this? Look, I'm not stupid. I've been reading on the internet. I went to the HRSA website and the Vaccine Injury Compensation Program, and I know that the government has paid out $3.3 billion in vaccine injury claims. How can you tell me there's not a problem with the vaccines when the government is paying out billions of dollars to injured children? Well, first of all, is that true? Absolutely true. What are you going to say? Does anybody know, where's my public health people? Is there a state immunization program person here? Or, what is your name? Stacy. Stacy, what is the Vaccine Injury Compensation Program?
It compensates people for an adverse event that happened. That's my.
And what is the proof of causation. In other words, I claim that I was injured by a vaccine and I want to be paid. Because you're mandating I get the vaccine to go to school, and yet I've been injured by the vaccine, so I want to be paid. What do I have to prove?
You don't have to prove causation. You have to have an injury and participate in the program.
So, you don't have to prove causation. You just have to have an injury that's listed on the injury table. So immunizations are one of the most important public health interventions there has ever been. It's akin to sanitation and clean water and that sort of thing. Literally millions of lives have been saved, and there are diseases that have been completely eradicated from the earth because of vaccination. And it's a little hard to put all this into perspective, but people still get sick from vaccine-preventable diseases. A good example of that is the flu. Thousands of people die every year in this country from the flu, and much of that is preventable.
Why is it still an issue? Why aren't people getting immunized?
Well, that's a really good question, and I think a large part of it is that well-meaning parents have become derailed, misled into thinking that the vaccines are more dangerous than the diseases that they prevent. And there's simply no evidence of that. In fact, it's absolutely untrue. The vaccines are safe. Sure, there are minor side effects and rare, very rare, serious side effects, but the benefit far outweighs the risk. And the risk is you get the disease and you may wind up in the hospital or you may die. I think if parents have questions, they should talk to their kids' pediatricians or family practitioners. And if you have a question as an adult, you should talk to your doctor and ask them, what have you done for yourself? Have you gotten the flu shot? What about your kids? Did they get the shots? I'm sure their answer will be yes.
Back to adults. If they miss their immunizations as a child, should they get them as adults or should they just skip it?
It depends on the vaccine. So there are some vaccines that are really geared towards children, and if they aren't received when you're a child, you don't really need them later in life. And a good example of that is the HIB vaccine, which prevents a form of meningitis that's very common, used to be common in infants, but once you get to be 5 or 6 years of age, you're pretty much immune to that bacterium. You don't need the vaccine unless you become immunocompromised in some way. But then there's others, for example, the measles vaccine or the chickenpox vaccine. If you never had those vaccines and you never had the diseases, you should get the vaccines.